Annual Summit on Antimicrobial Stewardship. My name is Jamie Jacob. I am an infectious diseases pharmacist, and I serve as the Antimicrobial Stewardship Coordinator in the HAI program within the Division of Patient Safety and Quality at IDPH. The Division of Patient Safety and Quality works to promote high quality, high value, and equitable healthcare for Illinois residents. The division develops and implements initiatives to improve the quality and value of our healthcare services. The division tracks and reports quality and patient safety outcomes and equips our patients to engage effectively with the healthcare system. The HAI program within the division has identified antimicrobial stewardship as one of its key priorities. Therefore, we've been working diligently to implement a number of exciting stewardship initiatives, collaboratives, grant opportunities, outreach campaigns, and educational materials to improve antimicrobial stewardship efforts across the spectrum of patient care. Today's summit is just one example of the Division of Patient Safety and Quality's commitment to antimicrobial stewardship. So we have an incredible list of speakers and exciting topics that we hope that you'll all learn from and bring back to your respective organizations to improve antimicrobial stewardship and mitigate antimicrobial resistance across our Illinois healthcare landscape. So without further ado, I am excited and honored to introduce our first speaker, Dr. Arthi Barnes, to deliver this year's welcome address. Dr. Barnes joined as the medical director of IDPH in 2021. Prior to that, she was the medical director for the departments of infectious diseases and specialties at the Cornell Scott Hill Health Center in New Haven, where she had also served as the infection prevention officer. She has an MPH with a focus in international health and humanitarian aid from the Harvard School of Public Health and served as clinical faculty at the Yale School of Medicine, UT Southwestern Medical Center, and the University of Mississippi Medical Center. She has also served as the clinical director for the South Central AIDS Education and Training Centers. She has experience in various public health systems across different states and expertise in infection prevention, HIV, transgender care, sexually transmitted infections, and HPV. Welcome, Dr. Barnes.
Thank you for having me here. And I apologize if for a barking dog in the background. But welcome to the 2022 Illinois Summit on Antimicrobial Stewardship. It is an incredible privilege for the Illinois Department of Public Health to be able to host this critically important conference at a time when infection prevention and control is prominently and deservedly at the forefront of everyone's mind. The public, the government, and the providers, albeit because of a global pandemic. Now, something very strange and paradoxical happened during this pandemic as more healthcare providers were wearing more PPE at extraordinarily high burn rates, and ABHRs or alcohol based hand sanitizers abounded wherever the eye could see. Hospital acquired infections went up. Went up. So, what happened here? What did we miss? Is our concept of how best to implement TBPs or transmission based precautions in strained healthcare settings too archaic, too naive? Did we underestimate our own human frailty in this equation? These are questions we hope to explore in the next few hours as we dive deep into the work of the leading experts we've gathered here today. So, why are the next few hours so critical? Antibiotic resistant infections led to, I would say, 29,000 deaths in the US this past year. That is almost double the number of people who died of HIV in the US this past year. Way more than double the number of people who died of hepatitis C this past year. However, our efforts to curtail this have us treading murky waters. Focusing on decreasing antibiotic use has also resulted in pharma companies de-emphasizing research and development in novel antibiotics. The better we get at decreasing prescriptions, the less they will develop them. So the question remains, is this a zero-sum game? Can we shut down antimicrobial resistance fast enough to not need novel antibiotics? Can collaboratives like CARB-X, CARB-P come to the rescue in time? Till that day, though, it is important for us to remember that every antibiotic resistant infection that we prevent today saves a life, not just today, but saves a life tomorrow. So this work is more important than it has ever been. And unfortunately, COVID-19 has not made this work easier. In spite of attention to all elements such as PPE, as infection prevention and control measures, 80% of the COVID-19 hospitalized cases received antibiotics in 2020. Mostly ceftriaxone and azithromycin, which is the magic cocktail for bacterial pneumonia. In nursing homes, azithromycin prescriptions jumped up 46% in 2020. Could this have played a very strong and inadvertent role in leading to the rates of and hospital-acquired infections going up almost 15%? And that we'll find out soon. At about 11 o'clock today, CDC's embargoed report for the 2022 antimicrobial infections will be released. So we need to keep an eye out for that. But there is good news. So Illinois invests more in antimicrobial resistance than most Midwest states, barring Minnesota and Missouri. But 93% of the hospitals in Illinois implement all 7 core elements of antimicrobial stewardship. And this is incredible. This is 3% more than the national average in 2020. And this progress is really rapid. Only about 48% of the hospitals in 2015 nationally even had any of these antimicrobial stewardship measures and elements in place. Other good news, outpatient antibiotic prescriptions are consistently improving. However, there is a caveat to that. The past 2 years, just prescriptions in general have been decreasing. And so, as we keep that in mind, as prescribing practices return to pre pandemic levels, this will be an important target to keep an eye on. Good news is Illinois has slightly lower community antibiotic prescriptions per capita compared to our Midwest neighbors. About 754 per 1,000 people received antibiotics in 2019. Can we do better? Can we actually get to a better place with this, closer to other states that have less than 500 prescriptions per 1,000 people? States like Oregon and Alaska, um, you know, so let's do this. All right. Over the next few hours, let's gather together and think about the next few decades, how we can reshape antimicrobial history, one provider, one prescription, one patient at a time. This is the long con, and we need to get our marks ready. So, si se puede, we can do this. Thank you. And thank you all for gathering here today. Your presence here is important, and I think we can do some incredible work here today. Thank you.
Thank you, Dr. Barnes, for your inspiring words. Next, we'll have Dr. Deborah Patterson-Birdsall present our Idph regulatory updates. Dr. Patterson is an infection control consultant with the Hectone Institute and the Illinois Department of Public Health. Welcome, Dr. Birdsall.
Hi, everybody. Can you hear me? Hello? Uh-oh. Uh-oh. I'm
Yep.
frozen. Can you hear me?
Yeah.
Okay. Thank you. Because my screen's frozen. So we'll just have to, hey, everybody, how are ya? I'm sort of running on minimum internet, so we'll hang in there. And if you could advance my slides, if I could have slide 1, please. And then move to slide 2. So figured we're going to start this out with antimicrobial stewardship and antibiotic stewardship, and it's always good to start with definitions because then at least we're all on common ground. And so I looked around for different definitions of stewardship and came back to the CDC definition. And, talking about what's antimicrobial stewardship. So we're looking at simple things, as Dr. Barnes so eloquently just said. How antibiotics are prescribed by clinicians, how antibiotics are used by humans, because that is another big issue. Yes, the prescribing can be fine, but then how they're actually used and administered can be another challenge. You want to make sure that you are effectively treating an infection and that the appropriate antibiotic is targeting the appropriate infection. You want to make sure that you're protecting humans from harm caused by unnecessary antimicrobial use. And what we're all here for is to combat antimicrobial resistance. Slide 3. So I'm Becky Dragoo could not speak. And I just want to say the Office of Healthcare Regulation has an incredibly difficult job trying to ensure that the guidance, the rules, the regulations are appropriately applied in real life. And it's a really, really large job. Centers for Medicare and Medicaid Services, CMS, are the ones that deal with this. And because, as you all know, my focus has always been pretty much congregate care settings, long-term care. It's what I know best. So when I start looking at things historically, I tend to run back to that. So I actually went back to the entire document. It's a 700-page document on the when Medicare in 2015 and or CMS in 2015-16 was looking at how to update OBRA with the reform of requirements for long-term care facilities. And there's some really, really enlightening and very interesting um, documentation in that. Basically, talking about the comment period and some of the really good comments they got about long-term care, but that really apply to all healthcare, the entire healthcare continuum. And I want to start there because, and this is a direct quote out of there, they supported this one commenter, and it may be somebody who's on this conference. They supported the effort to address antibiotic stewardship, but because these reform of requirements was for long-term care facilities, they gave this case study about a hospital emergency department. And those of you who've worked congregate care, this will sound very familiar to you. You send somebody into the emergency department, they get a urinalysis, they find some asymptomatic bacteria, the person's come in for congestive heart failure or something else like that. And the person comes back to you well managed, but with an antibiotic on board because they saw bacteria in the urine. Now, this is something that from 2015 to now, the entire healthcare community, thanks to stewardship, have really done a better job of addressing. But it is something that still, we have to work together as an entire continuum of care to prevent these issues with antimicrobial prescriptions. And this is one of the things they talked about. Now, if you go to slide 4, they also brought up the fact, and because I'm speaking in Becky's stead, I wanted to bring this up. More than other areas of the healthcare continuum, long-term care has to be focused on state survey. It's just a fact of life. A CMS survey can be a really onerous thing. And so what ends up happening a lot of times is they will look at the prescribing, and they're getting better at this. This is one of the reasons we're so fortunate in the state of Illinois to have the different agencies working together, because this case study where somebody got cited because an antibiotic wasn't prescribed, it's one of those things that this is why this is so important. Next slide, please. So slide 5. So Centers for Medicare and Medicaid Services. This was from 2016. It's crucial that long-term care facilities establish an infection prevention and control program that contains an antibiotic stewardship program. This was discussing in the proposed rule. Antibiotic resistance has become a national concern, and this is well stated, both inappropriate and even appropriate use of antibiotics. Long-term care facilities are part of the overall healthcare system, and as we have seen by some of the really amazing research that's been done by the Rush Epicenter, um, a lot of different groups within the state of Illinois, it does have a problem. The thing that I really, slide 6, and you're going to have to hit it twice because this comes in. It's the title. Within this reform of requirements, and this is the way it was originally published. So if anybody, if anybody thinks that some of this focus on infection prevention and control is new, it's not new. 2016 Basic Infection Prevention and Control Program. By 2017, Antimicrobial Stewardships, and long-term care, to its credit, has made great leaps and bounds with interdisciplinary antimicrobial stewardship, based in a lot because it was regulated in 2017. Now, I want you all to do a little bit of a sort of a mind game. Imagine what would have happened if there hadn't have been interference with phase 3. And November 28th, 2019, which is an important date to think about, each one of the congregate care settings had a fully trained and interested infection preventionist on board, because that is what the original CMS, what we used to call the mega rule, the conditions of participation, required, and that they were actively involved with the quality assessment and assurance and quality assurance and performance improvement. Next slide, please. But while we were working on this, so this is slide 7, COVID arrived. And I was going through my slides last night, and I pulled this slide from a January um, presentation that we did for Idph. And to me, it's staggering to think that January 27th, 2020, there were 110 persons under investigation. Slide 9. Now we're looking at this, the numbers of variants. With what I read this morning, it looks like BA5, 4, and 5 are now 70%. And it's amazing how fast these viruses can move from a place like South Africa to becoming a huge issue. So we were all scrambling. And the fact that you are still here working in healthcare after all of this emotional, and I mean, it's just been a horrible time for a lot of people, is a real credit to you. So please give yourself some credit. So slide 10, we were doing the best we could at the time, and Dr. Barnes hit the nail on the head. We did have clues that this would happen. There is a very good 2005 report from Alison McGear's team in Toronto about what happened with MRSA colonization and infection after the SARS outbreak there. And so we knew this was going to happen. But when you had people working in contingent and crisis capacity, not having enough PPE, it's going to take all of us a long time to unlearn some of these things that we have had to do because we just didn't have the supplies. So slide 11, please. And so, as Dr. Barnes was saying, while we were working, trying desperately to save people's lives from COVID, we had a silent pandemic of emerging antimicrobial resistance. Slide 12, please. So, June 29th, 2022, phase 3, which I talked about earlier, they are now getting to the point where they're talking about implementing it and requiring nursing homes to have infection preventionists with specialized training on site, oversee the facility infection prevention and control program, the facilities are responsible for effective infection prevention and control. Now, CMS did not go as far as the state of Illinois has, where we listen to me. the feeling is that to have effective infection prevention and control programs that with interested, trained infection preventionists to meet the facility's needs, it needs to be somebody who can focus on this specialty. For those of you who work long-term care, would be like having your MDS coordinator also be your DON. That type of thing just does not work. And CMS and CDC have a lot of good tools out there. They have wonderful training, wonderful tools. The Illinois Department of Public Health tried as hard as we can to support you going through what you have gone through, but this isn't going to go away with as once COVID becomes endemic and we settle down a little bit. So it's really important to realize that there are huge components of infection prevention and control programs, including antibiotic stewardship, that are going to need to be addressed. And that needs somebody who's interested and trained and has the time to implement. So, this is from CMS. This is right out of the memo. Strengthening the general infection control guidance, address frequently cited issues such as hand hygiene. It's not just training. You have to make sure that people are doing what you're asking them to do. And that takes time, as all of you know. But CMS believes the role of the infection preventionist is critical in the facility's efforts to mitigate onset and spread of infection. Slide 14, please. This is the last one. And this is actually from the thought process from this came from a 2014 study done by Septimus, Weinstein, Pearl, Goldman, and Yoke. And it talks about how basically these really pointed, COVID would be a good example, because our direction's been on this very vertical approach for one organism. And what happens is that horizontal approach, gets sort of overlooked until we start surveillance intensity. All of a sudden, you'll find things where you look. And all of a sudden realizing that there have been a lot of things that have been neglected, not because people have wanted to neglect them. It's because you've been hardworking on other areas and, just trying to save people's lives from COVID and now monkeypox and other things. But that's where you get into these thoughtful evidence-based approaches that are horizontal so that they hit more than one organism. And that's all I have. I hope this has been helpful. And I hope you heard me.
I think most people heard you. It looks like there are some issues with audio and video. It may be a firewall issue with a VPN access. So if you are able to join through your mobile device or just ensure that you're using Google Chrome, that might help in the interim. But we will work on updating that.
Okay, I'm going to get off and on again and see if this works.
I'm just going to remove you from the stream now. Thank you, Deb. Okay. So next we'll have Dr. Erin Kennedy present our dental updates. Dr. Erin Kennedy graduated from Nova Southeastern College of Dental Medicine in 2015. She completed a one-year GPR residency at a VA hospital in 2016, a dental public health residency in 2018, and a Master of Medical Science in Dental Education at Harvard School of Dental Medicine in 2019. She serves as the Director of Pre-Doctoral Education at Kansas City University College of Dental Medicine in Joplin, Missouri. Welcome.
Thank you all so much. It's an absolute pleasure to be here with you today. I'm thrilled to be sharing an update and to provide you a little context about what we've learned since 2019. I'm going to go ahead and share my screen, and hopefully you will be seeing my slides shortly. There we go. Well, the title of my presentation today is Antibiotic Use for Tooth Pain and Intraoral Swelling. It's the new guideline shifts mindsets in dentistry. And in 2019, right before the COVID-19 pandemic started, at the American Dental Association, we released a new set of guidelines to help guide clinicians for patients with tooth pain and swelling when they need antibiotics and when they don't need antibiotics, and in the context of the level of care that they're able to receive. And so since then, we've learned so much from implementing these guidelines chairside and at the policy level. And so today I'm going to give you the context of those guidelines, and I'm sure you're going to talk about it more or in more depth later today. And then I'm going to show you where our team has progressed and some of the new tools that help support the use of these guidelines in practice, and also just help with general antibiotic stewardship in your practices as well. So for my conflicts of interest, I'm employed as the Director of Predoctoral Education at Kansas City University, a new dental school in Joplin, Missouri. And so today, hopefully you'll be able to understand how these guidelines in 2019 have totally shifted mindsets in dentistry and have created spaces and resources for subsequent new resources when it comes to antibiotic stewardship. We're also going to go over the development of the guideline because it really gives you context in some of the resources that have come after. And we'll also talk a little bit about some of those resources as well. And I'll be able to provide you all with some links. And so our goal, and you all understand this, that anytime we have antibiotic use, it leads to this idea that there's appropriate and inappropriate use. And within the context of inappropriate use, when we created these guidelines, we really helped address unnecessary use, improper selection, dosing errors, and duration errors. And all of these changes and the mindset shifts that we'll talk about in the next 20 minutes or so helped address these different areas of inappropriate use within dentistry. And so before 2019, we had two columns of when we used antibiotics: preventing infection and treating infection. And all of our guidelines were within the context of preventing infection or prophylaxis. However, even if you look within the context of preventing infection, as a practicing dentist, there are only two guidelines available for very specific conditions. And for treating infections, we actually didn't have any guidelines, which was why the development of these guidelines that were released in 2019 was so powerful, is because when they were the clinical practice guideline and the subsequent systematic review and meta-analysis was released, we now were able to provide guidance for clinicians and primary care clinicians and emergency care clinicians when they had a patient come in with emergency tooth pain and swelling. How could antibiotics be safely used? And so our team was an absolute team effort. The guideline team that came together included dentists, pharmacists, emergency medicine physicians, an oral microbiologist, internal medicine physicians that had expertise in infectious disease, and also a team of public health researchers and experts to help the development of this complex guideline. And the reason I bring this up is because the summit today is not only an interprofessional experience, but we're all focused on not only interprofessional education of our teams in the context of antibiotic stewardship, but also interprofessional practice or collaborative practice. And so I think it's important when you look at guidelines to not only include stakeholders in the development of those guidelines that have influence or knowledge in that space, but it's also really important to include everyone that's on the collaborative care team for these conditions and for these patients, because that's when resources and ideas come to the table that really help make an effective implementation of guidelines such as this. In addition to those individual team members, there were stakeholders at the organized dentistry level or just organizational leadership level from different specialties and different organizations as well. And so when our guideline panel came together in collaboration with the methods team, we wanted to focus on urgent management of dental pain and swelling. And so if you read this guideline, it is not intended to provide guidance for antibiotic use when a patient has had a chronic abscess or a chronic dental infection or tooth infection. We also focused on immunocompetent adults, and so the target conditions and without additional comorbidities. And so when you read this guideline, it's important to remember that the recommendations are for immunocompetent adults, not children and not patients with immunocompromising conditions. And one of the major challenges and components that we brought into the guidelines and the subsequent chairside guides is that we wanted to make recommendations when patients did have access to immediate, definitive, conservative dental treatment, and without access to this care, because that level of access impacts the recommendations for safe practice. And the target audience for this guideline was primarily general dentists, but there are still plans to extend and expand this guidance for physicians, specifically targeting emergency room physicians, making sure that they have the resources they need for patients that come in with tooth pain and swelling at emergency rooms. And so the clinical questions we ask were this: when you have an immunocompetent patient with a vital pulp and definitive conservative dental treatment is unavailable, are antibiotics recommended or not recommended? And the same is true when you have an immunocompetent patient that has a necrotic pulp. And definitive conservative dental treatment is available or isn't available. What is recommended? And so you might be wondering, or what an update in oral health for you might be, what's the definitive conservative dental treatment? What's included in that? And the team came together and accepted a standard for treating pulpal and periapical conditions, which includes pulpectomy, pulpotomy, non-surgical root canal therapy, incision and drainage of abscess. But please note that this guideline does not include recommendations for if there's a tooth extraction that's provided. And so the reason these guidelines are so important is because there were a lot of different reasons that clinicians were, when surveyed, prescribing antibiotics. And part of it was an uncertainty. Part of it was barriers in the healthcare system or access to dental care. Some of it was patient expectations. And so these guidelines and all of the subsequent resources were really helped to address some of these concerns. And so overall, our team came together, and this guideline statement that I think is incredibly helpful is that the guideline states adults that are not severely immunocompromised, that are experiencing tooth pain and or swelling, are best served not by antibiotics, but by dental treatment, and if needed, over-the-counter pain relievers such as acetaminophen or ibuprofen. And this statement is so powerful because it really led to a mindset shift and different practice in dentistry. And so just a summary of the clinical practice guidelines. There's some really great resources. I actually have them here next to me. You can request a copy of these or print them directly off the internet, and links can be provided if you all are interested. But these clinical practice guidelines, a summary is that for when definitive dental care is not available, if a patient has pulp necrosis and symptomatic apical periodontitis, or when you tap on the tooth, it's painful, that's when a watchful waiting prescription is recommended, but immediate use of antibiotics is not recommended for an immunocompetent adult. And then when there's a localized acute apical abscess or systemic involvement, antibiotics are recommended, and the guideline walks you through those recommendations based on the patient medical history. And when definitive dental care is available, the recommendation that for antibiotic use is only when there's systemic involvement. So this would lead to a large shift in practice for many clinicians. And so what I always like to point out when I provide an update for oral health is the mindset shifts that have changed, because there were major shifts when we released this guideline. Many patients prior to this guideline might have thought antibiotics can cure my tooth infection. If I just go to my dentist again and get an antibiotic, that will work. And so the language that we suggest, and I've included some of the language from the toolkit that I helped create, but antibiotics cannot cure your tooth infection, but definitive dental care will cure your tooth infection. And another major mindset shift is that patients often requested an antibiotic and pain medication for their tooth pain. And so it was clearly stated within this guideline that pain can be controlled with combination therapy for over-the-counter medicines such as ibuprofen and acetaminophen. And I'll call back to this later because there was a huge shift and a dedication to developing a guideline for this combination therapy and some recommendations for patients with tooth pain because of what we learned in disseminating this guideline. And another mindset shift is that if I give an antibiotic, I have to tell my patient to start it right away. And there was actually a new term that was introduced that we've been using in medicine for a very long time in practicing antibiotic stewardship, especially in the context of upper respiratory infections. But if needed, I can prescribe an antibiotic and ask the patient to start it only if symptoms worsen or if certain symptoms develop. And that language and that recommendation was included in these new guidelines. Another mindset shift is on behalf of clinicians. Like, I'm going to prescribe an antibiotic just in case something goes wrong, or just in case, I'm missing something. And there is language in this guideline that I think is so powerful, and it recommends only prescribing antibiotics when they're absolutely needed. And that is a new mindset shift that has come across dentistry in the last few years. And so altogether, these new mindset shifts continue to help support the development and practice of antibiotic and antimicrobial stewardship in dentistry. And just some of the few key clear stewardship guidelines that are just really recommended in this set, or this release of guidelines, is prescribing first-line antibiotics whenever possible, and they walk through those in the chairside guides. Identifying true penicillin allergies, to make sure that more first-line antibiotics are to be used, and encouraged a shortened duration of use. And in fact, what's encouraged is evaluating the patient at 3 days or 72 hours, understanding their symptoms and how those symptoms have resolved, and then ensuring to make sure that you conclude the use of those antibiotics 24 hours after symptoms have resolved. And so with a shortened duration of antibiotic use and watching patients and evaluating after 3 days, and then concluding the use of those antibiotics 24 hours after symptoms resolve, it also sets our oral health care professionals and our team members to make recommendations so that patients can connect with pharmacists to dispose of any leftover antibiotics as well. And so in summary, I wanted to just give you context for these guidelines and for what I'm about to talk about, because I'm going to give you some updates, some hot off the press updates. But the development of guidelines really contributes to antibiotic stewardship in dentistry and creating a safer dental visit. This clinical practice guideline also suggests that we only want to use antibiotics when absolutely necessary. And the release of this guideline has shifted mindsets in dentistry and really encouraged antibiotic stewardship practices. But as we were disseminating, my team, other teams that I've been involved with, I've been involved with MAR over the past year, with OSAP with the Centers of Disease Control and Prevention, in creating what I call contributory resources for helping practice antibiotic stewardship. As soon as you start to implement these guidelines in your practice, you're going to realize, I need other tools. I need a champion for antibiotic stewardship in my practice. I might need a way to track or manage these cases so that I can evaluate and do evaluations of not only when I prescribe antibiotics, but when I don't prescribe antibiotics, and do a chart review. A lot of these materials have been included in state toolkits, very similar to the one that was created in the state of Illinois. But there have been other resources that we've needed. And so one is, when that term watchful waiting came into dentistry, we also needed similar resources. If you've ever gone to the Centers for Disease Control and Prevention, their website, there's some really great resources for clinicians managing upper respiratory infections that may go from viral to bacterial in patients. And they even have little prescription pads that say, make sure you do these things to help keep yourself healthy when you have an upper respiratory infection. But if things change, start this antibiotic. If you notice this, call your clinician, and then subsequently start this medication. And so the MAR Coalition did a fabulous job, and I've linked this at the bottom of this slide, but they've done a fabulous job creating this resource. And it was definitely an add-on and something that can really be helpful when you're practicing delayed prescribing. And the second is something that I had the opportunity to help create alongside MAR and OSAP. I helped lead a team to create this resource, but it's a penicillin allergy assessment tool. So one of the challenges that we noticed when implementing this guideline and when practicing and using these chairside guides is that it was difficult for private dental practices that have a separate electronic health record. And even when community health centers are linked in with a larger electronic healthcare system, there are a lot of patients that do not have a true penicillin allergy, but are marked as having a true penicillin allergy. And so we worked with a group of allergists, and we developed, based on some of their recent guidelines and some of the systematic reviews that have been published in their area of allergy and immunology, to create this tool that guides clinicians and dental team members when reviewing a medical history of when to, one, be able to prescribe penicillin and recognize a non-allergy effect. when to recognize different levels of allergic reactions, and recommend when penicillin allergy testing should be conducted or referral should be made so that the patient can be assessed by an allergist or another healthcare team member. And so this tool is really helpful in identifying that and maximizing the use of first-line antibiotics in the practice of antibiotic stewardship in the context of oral healthcare. And so you probably are laughing because as soon as we published this, which was just a few months ago, honestly, it was just right at the end of last year and the beginning of this year, we realized that we needed more resources. So because many dental offices are not linked to a larger healthcare system, we realized that when a patient is communicating between a pharmacist, a primary healthcare clinician, their dental team, and maybe an allergist or another specialist to verify or confirm whether they have a penicillin allergy or not and make subsequent recommendations, which is especially important in patients that have prophylaxis because this is going to be a repeated exposure to antibiotics. We want it to be first-line therapy if possible. We worked with OSAP and the CDC. We are currently in the process of using and conducting some patient-facing focus groups and research to create a patient-facing tool that helps with the communication and the relay. The goal is that this paper tool or this tool that can be held in your hands, it could also be applied to an electronic healthcare system to improve communication workflows in a larger healthcare system if that's possible. But it can also work in a way when you have to go analog, when you have different clinics that don't have a shared electronic health record. And again, the American Dental Association's acute dental pain management guideline is forthcoming. I don't have an exact date on that. I'm sure someone does, but I kind of alluded to that earlier. When we were releasing this guideline and we were talking about combination therapy, it was apparent to our entire team very quickly that that was another resource that we needed in dentistry, was how to manage acute dental pain safely, especially in light of the opioid crisis that we're facing, and that's such a public health threat and concern. And so those are different resources that are forthcoming. I'm also a part of an OSAP and CDC team that's creating additional and updated patient-facing resources to educate patients on safe antibiotic use. So there are a series of resources that are going to be coming out over the next 6 to 9 months, maybe the next year, and they are all in response to this guideline. So when they asked me to do an update, I'm like, I have to set the context because that context shows that we have identified resources that patients, that clinicians, that dental teams need, and they're now available so that they can be included in antibiotic stewardship programs and in the practice of antibiotic stewardship chairside. So I just wanted to say thank you, not only to everyone on the slide, but to all of my friends and colleagues at the CDC and at OSAP. I really appreciate working with you, and I found all of our work incredibly fruitful. I am at the end of my slides. I highly recommend you check out any of the American Dental Association resources that I referenced today, the guidelines, the chairside guides, and there's some additional patient-facing resources as well. And I'm going to go ahead and stop sharing my slide. I know that we have a Q&A coming up, and I'm happy to answer as many questions that I can.
Great. Thank you so much, Dr. Kennedy. Next, we'll have Dr. Melinda Newhouser from the CDC to provide updates on antimicrobial stewardship. Melinda Newhouser is a pharmacist and acute care lead for the Centers for Disease Control and Prevention, Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion. Melinda earned a Doctor of Pharmacy from the University of Minnesota College of Pharmacy and a Master's in Public Health from Johns Hopkins Bloomberg School of Public Health. She has also completed an infectious diseases residency at Detroit Receiving Hospital and an infectious diseases fellowship at the University of Illinois at Chicago. Welcome, Melinda. Thank you for being with us today.
Thank you, Jamie, and thank you for the opportunity to provide updates in antibiotic stewardship from Office of Antibiotic Stewardship perspective. Next slide. I have no financial relationships or disclosures. So today I'm going to describe the CDC's Office of Antibiotic Stewardship mission, goals, and ongoing activities leveraging antibiotic use in hospitals, outpatient settings, and nursing homes across many settings. And I'll also identify CDC resources for antibiotic stewardship implementation. I'll just highlight a few. And as you just heard, there are many more that are going to be coming. Ensuring appropriate use of antibiotics is one of CDC's 5 core strategies to combat the threat of antibiotic resistant infections. Next slide. The main mission of the Office of Antibiotic Stewardship, where I work, is to improve antibiotic use and optimize the treatment of infections. The goals listed here are goals for the next few years, and I'll describe specifically the activities that we aim to achieve under each goal in the next 15 minutes. To start off with a more general background, I wanted to highlight that the hospital core elements of antibiotic stewardship is the framework that CDC released in 2014. So many of you are very familiar with them, and we updated in 2019. The core elements outlines the structural and the procedural components that are associated with successful stewardship programs. The 7 core elements are listed here: the hospital leadership commitment, accountability, pharmacy expertise, action, tracking, reporting, and education. The core elements are intended to be an adaptable framework that hospitals and other healthcare settings can use to guide efforts to improve antibiotic prescribing. Since 2014, the core elements have been released for nursing homes, outpatient, small and critical access hospitals, and resource limited settings. And these documents take into account the unique challenges and resources in these different settings. Next. The CDC core elements of antibiotic stewardship play an important role in regulatory and accreditation stewardship standards. In 2019, CMS published a final rule requiring hospitals to have a stewardship program. And earlier in this month, just last week, the interpretive guidance was published. In 2023, so this upcoming January, the Joint Commission will have new and revised stewardship requirements that will apply to all Joint Commission accredited hospitals and critical access hospitals. And the links for both of those documents are on the slide. Similar to nursing homes, CMS issued a final rule requiring nursing homes to have a stewardship program integrated within their pharmacy and infection prevention and control programs. And the interpretive guidance was published in 2019, which emphasizes that nursing homes should have a system to monitor antibiotic use. So the first of activities I'm going to focus on is leveraging antibiotic use data to identify where improvements in antibiotic use is needed. So really the surveillance. Next slide. The National Healthcare Safety Network, or NHSN, once again, many of you are very familiar with this, is a widely used healthcare associated infection tracking program. And it also has a mechanism for tracking antimicrobial use data in hospitals, which we call the AU, or antimicrobial use option. The main objective of the NHSN AU option is to facilitate risk adjusted antimicrobial benchmarking and evaluate trends over time. This is voluntary reporting at this time, and it does not include patient level data. So CDC does use other data sources such as Premier or MarketScan, more like administrative database, also to conduct surveillance for antibiotic use in the hospital setting. The number of hospitals submitting their antibiotic use data to the AU option has been steadily increasing since 2016, with just over about 24 hospitals that have reported at least 1 month of AU data. It is only electronic reporting, so it relies on vendors, and you can see that we now have many more vendors that are providing this for hospitals, and has really contributed to the increase of submission over the last several years. Here you can see the percent of facilities reporting their AU data across the United States, with Illinois showing an uptake of 35%. The standardized antimicrobial administration ratio, or the SAR, is a summary measure available to hospitals participating to AU. So this is observed or predicted, very similar to the SIR for our IPs out there, and but it's specific to antimicrobial use. So it's called the SAR. The summary of the SAR distributions and the percents of use within each SAR antimicrobial category for adults, pediatric, and neonatal patient care locations have been posted in over the last 2 years in what we call the NHSN data report. And this enables hospitals to compare SARs to national distribution and potentially see where to improve if it's clinically appropriate. And we're going to be posting our new report with 2021 data by US Antibiotic Awareness Week, which is in November. The Antibiotic Resistance and Patient Safety Portal, which is a screenshot here, and we'll be referring to this a lot throughout this presentation, is an interactive web-based application that was created to innovatively display data collected through various CDC data sources such as the NHSN, the AR lab network, and other sources. And it offers an enhanced data visualization on antibiotic resistance, use, and stewardship data sets, as well as HAI data. And we are planning to post state level SAR distributions on the portal later this year. The patient safety portal also displays outpatient antibiotic prescribing data based on the IQVIA data. And similar to hospitals, we use multiple data sources, mostly administrative data sources, to characterize antibiotic use in the outpatient setting. This data allows us to identify and focus on high prescribing settings. We characterize higher rates of antibiotic prescribing in the southern census, as well as the urgent care settings. And the COVID pandemic really highlighted challenges in appropriate antibiotic prescribing in telehealth settings, which we are now engaging with partners to identify strategies to improve antibiotic use. We recently published an MMWR that highlighted the use of publicly available CMS Part D data to identify higher volume of antibiotic prescribers for public health interventions. This is for health departments across the country to potentially utilize this data source. We also released an analytic guide for using these data for peer comparisons, audit, and feedback. And the link to the MMWR and the guide are on this slide. Unlike other settings, we do not have a large data source to characterize AU data in long-term care. In the last few years, we have engaged with long-term care pharmacies and electronic health record vendors to characterize AU in these settings and then to compare different data elements in these sources. And we recently published the results of a cross-sectional survey, or like a point prevalence survey, of characterizing antibiotic use on a single day in 161 nursing homes, which is a screenshot here. And we plan to incorporate the lessons learned in both of these projects to the tracking and reporting appendices of the nursing home core element documents. So hopefully next year I can highlight that they've been posted. During the COVID pandemic, we were able to quickly pivot and use these different data sources to characterize antibiotic prescribing in the different healthcare settings, as shown by the different publications here. And we really use this work to continue to leverage lessons learned from the pandemic moving forward. Now, we discussed antibiotic surveillance, and so next I'm going to focus on advancing the assessment of appropriateness of antibiotic use. In hospitals, the CDC Emerging Infection Program, or the EIP program, had a point prevalence survey that included a component of appropriate use antibiotics, which we call AQUA. And the results of this analysis was published last year and are highlighted on this screen. The plan is to have a follow-up of these point prevalence survey called AQUA, specifically for antibiotic use in 2023. And then we can compare the data derived from 2015 to 2023 to see hopefully an improvement of antibiotic use prescribing. In addition, we are funding several partners to develop and evaluate electronic measures of appropriate use for inpatient community-acquired pneumonia. Okay, based on the core elements framework, oh, you can keep going to the next. Okay. Based on the core elements framework, we're assessing and supporting stewardship implementation as well. In the inpatient settings, facilities, as many of you know, fill out an NHSN survey on an annual basis that includes reporting for stewardship activities. And these data are posted once again on our AR and patient safety portal as illustrated here. And with ongoing engagement with regulatory and accreditation partners, we have over 90% of hospitals that self-report that are meeting or having an uptake of all 7 core elements. And that represents a twofold increase since we started monitoring in 2014, and actually a fourth-fold increase for critical access hospitals. We plan to establish what we're calling priorities for hospital core element implementation, for really to emphasize for hospitals that are already meeting all 7 core elements, what are next steps that you can continue to enhance your stewardship program. And here are some examples on the slide of what we consider priority implementation, such as for action, having prospective audit and feedback or pre-authorization coupled with facility-specific treatment guidelines. We will incorporate these criteria or priority implementations into the patient safety portal for fall and really launch this enhancement during US Antibiotic Awareness Week. So more to come. In the outpatient setting, we are engaging with healthcare providers to support stewardship implementation and develop a toolkit for healthcare payers to improve antibiotic prescribing. And we also are funding partners and professional organizations for stewardship interventions in high priority settings. And you just heard about some of that for the dental setting. Similar to hospitals, we characterize nursing home core elements implementation using the NHSN long-term care annual survey, and the uptake of all 7 core elements has increased in nursing homes. And we plan to incorporate these data once again into the portal, hopefully later this fall. We conducted a qualitative review of public database that contains CMS stewardship deficiency citations issued by state surveyors during nursing home facility inspections to identify gaps and where support is most needed. And here's some shown on the screen. And then lastly, when we're evaluating, and we are really prioritizing evaluating and ensuring health equity and antibiotic prescribing and stewardship under all the different activities that we just presented. We are currently exploring new and existing antibiotic prescribing data sources and working on a narrative review of the literature to highlight where further data is needed. And a portion of the American Rescue Plan funds, actually $120 million, is dedicated to antibiotic stewardship and health departments, as well as some of the large health departments such as Chicago. And it aims to provide access to stewardship expertise and support for stewardship implementation across different healthcare settings. Lastly, I'm going to present a few examples of educational resources and materials posted on the CDC website. A few years ago, we released the 5 ways hospital pharmacists can be antibiotics aware, and those material have been adapted to nursing home settings, which was released this past year, and community pharmacies should be coming soon. We're just undergoing our last phase of clearance and hope that will be posted by US Antibiotic Awareness Week as well. CDC developed resources for healthcare professionals to optimize antibiotic treatment and improve communication at hospital discharge. We know transitions of care is very important, and it highlighted the key prescribing elements that should be communicated across the transitions, especially when patients are discharged to nursing homes. We know that family pressure has been identified as an important reason for inappropriate antibiotic prescribing among nursing home residents. And these tools were adapted from communication principles from the outpatient setting to help nursing home healthcare professionals better communicate with residents and families on antibiotic treatment expectations. So the first page on the left is Effective Communication with Residents and Family Toolkit that reviews this communication strategy. And then there's two nursing home specific scenarios applying these principles that are presented afterwards. CDC has training on antibiotic stewardship. We've been highlighting this for many years. I just wanted to say that we are actively updating. So if you previously received CE, there are some new modules that you can get CE again, and we are updating the remaining ones this upcoming year. It provides about 10 hours of complimentary CE for healthcare professionals, which include physicians and pharmacists and nurses, and most of it is focused on outpatient prescribing, but there is a general stewardship section, the first three modules, and then we do have specific modules also on hospitals as well as nursing homes. So it's really, and there's a dental, so there's something there for everyone. And I wanted to really highlight that U.S. Antibiotic Awareness Week that I mentioned several times is November 18th through 24th. So encourage you to participate at your hospital or clinic or dental office, as well as continue to click on this link because we'll be posting more opportunities for material as well as opportunities to participate with the CDC. And at this time, really want to thank everyone for this opportunity, and I think we're going to transition into the panel discussion.
Thank you, Melinda. Yes, now we will start our Q&A portion of today's presentation. So we'll have our incredible panelists join back on screen. We'll have Dr. Arthi Barnes, Melinda Newhouser, Erin Kennedy, Deb Birdsall, and Karen Trimberger will also be joining us. So if you could please just enter your questions into the chat to the right-hand side of your screen. I will share them on the screen for our panelists to answer. So we'll just give it a few seconds for everyone to start answering questions, and I will add our panelists to the stream. I'll just go through to see if anyone has asked any questions thus far. It looks like it's primarily just issues with joining.
Jamie, can they unmute and ask questions live too?
Not in this portion. For the later sessions, they would be able to. For now, if they could just place their questions in the chat, and we can actually broadcast the question onto our screen so everyone will be able to see it.
And I just want everyone to make sure you're please using the stage chat feature. We did just get a question into the event chat. Somebody is asking, how can we as a facility subscribe to the NHSN AU program?
Yeah, that's a great question. And in order to submit data to the NHSN AU option, it is all electronic. Therefore, it really is optimal to have a vendor that already has the configuration. There are some facilities that do what we call homegrown, which do it within internal IT department, but it's a lot of work. And if you go to, there's two websites. One is the SIDP AUR vendor list, and that is self-reported by vendors such as electronic health record vendors or like infection control and stewardship surveillance vendors, as well as some smaller vendors, if they're reporting to the antimicrobial use option, as well as there's also antibiotic resistance arm. So it's really antibiotic use and resistance module. And then CDC also, which I can put in the link, has a vendor list also if we now have it's called a synthetic data set where you have to undergo validation as a vendor in order to submit. And so those vendors that have undergone successful validation are also posted.
Thank you,
And
Melinda.
yeah, and I guess one more thing, we actually do have another, we have some, when I'm done talking, I'll put in the website also. We do have a great resource on our website of how do you get started. So if you have a vendor that potentially could submit, then that's also a great way. There's so many. I know I was very, I only had 20 minutes, so I was very high level, but we every year we have NHSN AU training for all the modules. But within that, there is about 4 or 5 hours that's posted on our websites that go into the AU option in great detail. So that's if you want to learn more about it. There's endless amount of resources on our website that I'll post. So thank you.
Thanks, Linda. I think we do have another question for you as well. It looks like some people are entering their questions into the other chat. So I've just copied and pasted them here. So I will just post this first one onto the screen for everyone to see. The question is from Sydney Miller. Is there anything new we should expect from the CDC for Fungal Awareness Week?
That is a great question, but I actually don't know the answer. I'm not. We do collaborate with our fungal group on different projects, but for Fungal Awareness Week, I haven't been involved in that. So I hope you get involved though.
Okay, our next question is for Dr. Kennedy. What are your thoughts on daily low-dose doxycycline used to help treat periodontal disease?
Well, my first thoughts are we actually have some resources for that. So I don't know if you see I moved closer to my screen, but I'm going to drop this resource in the chat. It's actually from the American Dental Association website, and it talks about treating periodontal disease as a whole when you use adjuncts and when you don't use adjuncts. So depending on the case for your patient, their medical history, the diagnosis of their periodontal disease, there might be various recommendations with what you have available. And so there isn't one specific answer to what you're asking, but this resource that I just linked in the chat for everyone is really helpful in guiding when you should use antibiotics and when you shouldn't use antibiotics in the context of treating periodontal disease. What I will say is that there are some really great resources, but our team, when we were discussing where we have clinical practice guidelines and the resources going into periodontal disease, going into patients that have immunocompromising conditions, even providing resources for children, those were all things that we discussed in that context. And while I can't speak for the organization as a whole, I know that everyone on that team is looking to create additional resources and guidelines to expand how we guide antibiotic use in dentistry so that stewardship resources are available for all conditions and all treatments.
Thanks, Dr. Kennedy. Our next question, it says, Deb mentioned toolkit for Illinois. How do we find those? Deb, do you want to take that question?
Sure. Actually, I think somebody else mentioned an Illinois toolkit. I've actually used, if we're talking about long-term, yeah, I think somebody else may have mentioned that. But for long-term care, CDC has wonderful toolkits. The other thing, and what I will try to do is find it and put it in the chat. For some reason, I can't comment in the chat. I'll drop it in. Minnesota actually has a really amazing long-term care antimicrobial stewardship website. And the other thing that it has, which is another real plus for it, is it will do days of therapy for you. They have an Excel sheet that automatically calculates days of therapy, and it actually can be used as just your basic surveillance line list. It's a lovely tool. So I will find that and give the link to Shannon so she can put it in the chat. But CDC has wonderful stuff.
Yeah.
And if I could just chime in, I was the one that mentioned the Illinois toolkit, but the state of Illinois had a fabulous team that a few years ago developed an antibiotic stewardship toolkit for dentists specifically. And I don't want to claim that they were the first, but in my book, I've been doing this for quite a few years now, and they were the first that developed an awesome toolkit. And after that, other states followed. Massachusetts, Minnesota has some great resources, Michigan. So there were other states that followed. And so I also put this in the chat. It's a link to the PDF. And it's a really great resource and was something that I used in my practice before some of these other resources came about. And now I use a combination of a bunch of different toolkits to practice antibiotic stewardship in a clinical dental office.
I'll also add, I will link to the Antimicrobial Stewardship webpage as well. We're working on updating that, but the link to the Stewardship Dental Toolkit is there, as well as access to the PDSB campaign. And we do currently have 2 ongoing grants with 2 awesome grantees who are working on outpatient toolkits as well as long-term care toolkits as well. So keep an eye out for those. When those are completed, we will post that to the Antimicrobial Stewardship webpage as well, which I'll link in the chat right now.
And we usually recommend the CDC toolkits to many of our long-term care facilities because the implementation guides and the appendix that they have on the website are really, really helpful to facilities to begin that journey down antibiotic stewardship.
Exactly.
So the next question, also copied over from the stage, it's not from Shannon Kalis. It states, as part of an ASP, it is integral to de-escalate from broad to narrow spectrum antibiotics. There should be a stronger focus on this. So I guess not a question, but I wonder if there are any resources that our panelists can provide that can help stewardship programs work on this.
Yeah, Jamie, I can add. I didn't highlight today, but within the core elements, we do have a table for community-acquired pneumonia, SSTIs, as well as UTIs. We really highlight opportunities to optimize antibiotic use at the diagnosis, as well as empiric therapy and what we call definitive therapy, which would be, as stated there, like the opportunity to narrow down, as well as the duration of therapy. So would for individuals to that as well.
And for those and additional resources, the Infectious Disease Society of America has a lot of very concrete practical guidelines, and a lot of the IDSA guidelines also focus heavily on de-escalation and when to de-escalate, at what point. The guidelines are broken down in 2 ways on the IDSA website. I'll put that into the chat. One is, of course, by the organism, so you can look by that, and the other is by the condition. So if you're looking for, say, prosthetic bone and joint infections, or certain like cardiovascular infections, so that you can search based on that too.
And we'll definitely take this into consideration as we work on our stewardship educational materials from IDPH as well. So thank you for that comment. Next, we have a comment from Amanda Kaplan. She asked, we find a huge amount of our time in stewardship is spent collecting and managing data. Are there any discussions out there about ways to provide data on a national level to reduce this burden?
That's for me. And right now, as I mentioned, the NHSN AU option is a mechanism that we have for standardized submission of AU data electronically. There definitely is some work at the facility level to configure the system with your vendor and IT department and validation. And we do have an implementation validation protocol at baseline, and one that we encourage every year to utilize. We recently just funded academic partner that has extensive experience with using AU data within a network of hospitals. And we're funding them to really provide practical examples of using the AU data for action. And so we hope to have that within probably next year, next fall, posted as a resource for everyone. But thank you for that comment.
Thanks, Linda. Our next question comes from the other chat as well. Does the CDC have any data related to COVID patients in ICU and when prescribing antimicrobial therapy?
Yeah, from the COVID perspective, we have two data sources. One that we utilized was the Premier data source, which is an administrative database. And on my slides, there was a publication that was the first 6 months of the pandemic, and we highlighted the antibiotic use based on COVID burden. And then the other data source that we, of course, have is NHS and AU data. And we do know the patient care location that the patients were in. And we presented both the Premier data and the AU data through the PACCARB presentations. There are several of them. And I can put that link in. And I think our last one was in the fall of 2021. And then we also had one earlier. I mean, we had several, but from 2021 perspective. And it does highlight antibiotic use in terms of broadly, but not, I don't think we were as granular in terms of ICU patients. So I think the key here would be that the Premier manuscript that we had published. And I can put that in the link.
Thank you. Our next question, in light of the COVID-19 pandemic, has the use of antimicrobial agents increased compared with previous years?
Yeah, and it depends on the patient setting or the setting. But what we found from an inpatient perspective was that overall antibiotic use did not necessarily increase, but there was an increase in agents that we would commonly think that would be used for a pneumonia-like indications, such as ceftriaxone and azithromycin. And you can see kind of with the waves of COVID, the increase in those agents. And that's nicely displayed on the PACCARB slides that I can put in the link.
Thank you. The next question, is there work with the field of dermatology to find alternatives to chronic antibiotics for acne and rosacea? I'm not sure who'd be able to answer this.
Yeah, from a CDC perspective, we're really working with many partners, but I do not, like the Office of Antibiotic Stewardship, I'm not sure if that partnership extends to dermatology, but we can definitely bring it back to our team and see if that's an opportunity.
Yeah, definitely something to consider. Next, for Deb and Karen, some long-term care facilities have begun their stewardship journey. Many have a way to go. For the newer IPCs recently hired, are there any advice on first step?
I'll let you go first, Deb. And
You
then
want me to go first? Okay.
Yeah.
Okay, so it's important to have a good communication with your medical director and whoever your prescribers are first, so that you are sort of understanding as far as where you are. A lot of times your pharmacies can provide you lists of antibiotics prescribed by prescriber, which is also helpful. Just knowing more about antimicrobial stewardship and the importance of it. CDC, I mean, you've heard, start with the basics and learn exactly why antimicrobial stewardship is important if you're a brand new IP, because that's really important too. Tracking, trending. It's one of the reasons the Minnesota document, that Excel file, is so good, because it can show you days of therapy. It can show you a lot of other things, and it's really not that hard to use. It's really easy, and you don't need a lot of computer skills to use it. Let's see, what else would I say really quickly? The other, Okay, this is going to sound a little crazy, and those of you who have heard me talk before know about this. And Dr. Newhauser talked about this. You have what I used to fondly call daughter-driven antimicrobial use. You need to find out from your interdisciplinary team who your frequent flyers are when it comes to antimicrobial use and where the requests are coming from. You may have a few people, and sometimes the best antimicrobial stewardship activity you can do is to get to the family members who feel that the best way they can help their parent is by, my mother, I came in, she was tired, she wasn't working well, she wasn't talking to me, she must have an infection, so she needs an antibiotic. And you will find that those people a lot of times know that if they call at 9 or 10 o'clock at night and get the staff nurse that doesn't quite understand to call the on-call physician, all of a sudden you end up getting this cycle of antimicrobial use that is harder to stop once it's gotten into effect. So direct communication and clear communication and education with residents and CDC's got those kind of tools that can really help you. So those are some of the places I'd start.
I was going to say that I would start on your units or on your wings. Look at those line lists that your staff or that the floor nurses are actually documenting on when an antibiotics was started, what the resident may have, those types of things, and get a feel for, how much antibiotics are really being prescribed, and the days of duration, and then work with your pharmacist, probably a consultant pharmacist, look at those prescribing practices. And then once you kind of get an idea of what the lay of the land for your own facility of what's happening, then you can get back into working with your medical director, trying to come up with policies related to prescribing practices, et cetera. But first, I think you just need to dive in and just figure out what's going on in your building first, because it's different everywhere. And I know when I've done a lot of the ICARs, I've asked people when we talk about antibiotic stewardship, if they know if there's policies about prescribing antibiotics, what physicians particularly need some education pertaining to that, because maybe they order them for everything, those kinds of things. So my suggestion would be, if you're going to start out new, just get a feel for what's going on in your building first. Then you'll kind of start walking up the mountain.
And just to add an upcoming collaborative from the IDPH, we do have the PALACE Collaborative, which is the Partnering Acute and Long-Term Care to Advance Stewardship Efforts Collaborative, where we'll be partnering hospitals with nursing homes and long-term care facilities within their referral network to help implement antimicrobial stewardship programs in long-term care settings. So this year will just be a pilot. We're in the preliminary planning stages, but we do hope in the coming years that we can expand upon the number of facilities that are involved. So that would definitely be a great way for new infection preventionists to get involved in implementing stewardship at their sites as well. So the next question we have: most hospitals, including urologists or ID, orders methenamine hypurate for chronic UTIs, if not UTI prophylaxis. What are your recommendations, given that some of these residents sometimes become symptomatic, and per urine analysis, culture and sensitivities, another antibiotic is prescribed?
Right, so I'll take this. I think so if you're thinking about just chronic UTIs outside of the context of a catheter, like if you're thinking about residents who have chronic indwelling catheters, then unfortunately you really want to avoid using antibiotics for even as a measure of preventing COTIs, or what we call chronic catheter associated UTIs. It's a very limited benefit of using chronic antibiotics in recurrent UTIs in menopausal, postmenopausal women. Again, that's an approach. These guidelines are old for the most part. Like, there's not been a lot of recent research on it, and I think in the past decade at least. But the American College of Urology promotes using say like Bactrim once a week or weekly, thrice a week, for preventing that in women who are postmenopausal. So it depends on the situation in which you're really thinking about treatment for chronic UTIs. Urologists favor this. If you look at infectious disease providers, they don't really favor chronic UTI, antibiotic prophylaxis with chronic UTI. So there is a difference between which type of provider is prescribing this treatment. So my recommendation would be, usually if there is a recurrent UTI in a resident, especially someone who's frail, there is a reason for a recurrence. Usually it's a neurogenic bladder or some reason, sometimes for the UTI. And so the focus should always be addressing the cause of the UTI rather than just treating it prophylactically. There might be some exceptional circumstances in which you cannot address the cause and you cannot really manage it, and you know this person has a history of really developing complicated UTIs. Like every time they get an infection, it goes all the way up to the kidneys. Those are some unique circumstances, but those are very individualized, case by case, call your ID doc kind of situations, where I would say before you think about chronic antimicrobial prophylaxis, just get an infectious disease consultation just to make sure that all other avenues have been explored.
Thank you, Dr. Burns.
Sure.
Our next question from an ICP in long-term care: seeing increased frequency in doctors wanting to start an antibiotic, even sometimes being a one-time Rocephin dose for UTI symptoms while waiting on UA results. How do we say no to this prescribing?
So I think one smooth way of doing it is to really ask, you can truly show or ask, whether this is a specific guideline that they're following, and then, put them on the spot, and often say, if it's, feel free and feel confident to say, hey, doc or provider, is this, we heard that, there might be an alternate to antibiotics in terms of management of this UTI. If it is a frail elderly person, I think they're very worried about this UTI becoming complicated and resulting in easy delirium and or sepsis in a frail elderly person. So there is some clinical judgment involved here, but for the most part, it's if someone can wait, doesn't have any systemic signs of infection, they have a UTI, but they don't have, say, fever or any abdominal pain, then you can say, it's worth waiting. So find a way to sort of gently push back, but this pushback is important. I think when we don't question practices like this is when they run rampant. And so please gently and persistently question when you suspect, and sometimes it's justified, but then that'll also give you a sense of comfort that this person is truly getting it because they need it. A lot of the times, again, this is in the setting of what we refer to as asymptomatic bacteriuria and not a true UTI. And that is a challenge. A lot of UTIs are not really UTIs. So the first question I always ask is this truly UTI? And if someone has dementia, cannot really endorse symptoms, say if they're on a memory care unit in a long-term care, it can get challenging, but there are still ways to determine more definitively if this is a UTI, just what we refer to as asymptomatic bacteriuria. Like, why was the urine checked? What did you find on the urine? How good was the urine sample? I mean, and what kind of bacteria were growing out from there? A lot of those can help you determine also if this is a genuine infection or just bacteria that are hanging out there in the urine that honestly do not need to be treated at all.
So our next question: as part of the ASP program, there should be an emphasis on not prescribing antibiotics that have become resistant. Sometimes providers are not aware of the latest antibiotic trends. Again, not really a question, nor just a comment, but I don't know if you had any thoughts or feedback on that particular comment.
Yeah, I think you should challenge it. It's hard sometimes when you're looking at an antimicrobial report. Not all providers are very educated in terms of understanding what you get a printout. It says, okay, this is something called MIC of to ciprofloxacin to say pick a to another antibiotic, ceftriaxone, and they may not realize that they might see numbers, not know that a lower MIC does not necessarily mean that it's for that drug, for that pathogen, for that route of infection is the best option. And so one thing we can do is really try to get a little more education out there. We do that sometimes even for COVID therapeutics. If we hear that there are prescribing practices that are a little outdated, then we try to do one-on-one outreach. So this is your opportunity, even if you feel a little uncomfortable. And I want to reiterate that if you feel uncomfortable addressing this with your providers, you can also again reach out to us, and we can hold a very gentle educational session that's for all the providers at the institution, an update that just reminds them of some of the guidelines and practices. So we'll be happy to do that.
And I think a lot of the pharmacy consultants will contact the providers if it's an inappropriate antibiotic, or should be. So again, if you've hired somebody at your facility and you're noticing that it is not the appropriate antibiotic, there should be a conversation with the pharmacist as well, and understanding that process as far as, when there is an inappropriate use, do they contact the the provider for you, or does somebody else need to do that? Whose role is that to contact that provider and say, hey, this isn't the optimal drug of choice for this bacteria.
Yeah, and this is Deb. Antimicrobial stewardship makes great QAPI projects, and CMS has a great toolkit for the processes of how to do a QAPI project, and working with your quality assessment and assurance team and your pharmacist. Karen's exactly right.
Thank you. The next question is, my facility is HFAP accredited. There was mention of updates to the CMS and recognition guidelines. Any guidance on HFAPs?
All I can add is that Mary Alice, who was going to be in the panel, she's having difficulty getting in. She tried to access that, and because we're not a member, she is unable to access that. So unless one of the other panel members know, not quite sure as far as what those guidelines say, or be able to answer this question.
Perhaps Mary Alice can actually just enter her comments into the chat as well in the interim. I think we can move on to our next question. What are the best resources for guidance for starting an antibiotic stewardship committee within a long-term care facility?
I can start with that. Actually, I've just put in the chat the CMS QAPI toolkit, but working with your pharmacist. I don't know what I would have done without our pharmacies and our pharmacists and their ability to tease out exactly what Karen was talking about earlier, and what a lot of the panelists have been talking about. You have to know what's being used, who's prescribing it, and why. And so starting an antimicrobial stewardship program is like anything else. You have to know what's really going on in your care community. So that's important.
And I would, again, take you to the CDC website, look at that toolkit for long-term care, look at the implementation guides, look through those appendix, which they have line lists, et cetera, those types of things. And just because it's a toolkit, you're going to start from, the top and work your way down and implement, a couple things to get started, get your team rallied around who's going to help look into some of this, collect data, et cetera. And then you're able to manage by fact then, because you have the data in front of you. But I would, again, as far as resources, I'd say CDC is the best one good place to start.
Next question, Dr. Kennedy, do you know if the ADA plans on making a recommendation that dentists would be required to document indications for antibiotics when they are prescribed? This would help on point prevalence surveys to assess appropriateness.
Great point. That is something that I've been in many discussions with. And basically, just so that everyone, if you're in a dental office or take part or practice antibiotic stewardship in a clinic or not, in dentistry, we actually have a lot of treatment codes, which are codes that go through, but they are often not linked to a diagnostic code, and there isn't regular use of diagnostic codes in dentistry. So we still diagnose, and we have all the frameworks to do that. But the use and the link of all of these data is just not, it's where we're going in dentistry. It's something that we're working on. In the chat, I did put in a CDC resource for a checklist when prescribing, because I think it makes the point that it's essential and it's absolutely required to have a diagnosis before prescribing. Because if you don't have a diagnosis, then there's really no reason or evidence base for prescribing at all. And I'm going to drop in the chat one more resource. It's the Massachusetts State Toolkit. There's a PDF, but also a download in there that you can use. And I worked with the team in the UK. They have some fabulous resources for dentists all across the UK. And when I was implementing in my practice, I realized we needed a tool to help guide prescribing, a way to document, almost like a note template that would then lead to the ability to prescribe. And so one of the things that I was able to help implement in some community health centers in Massachusetts was this tool. And I've seen it used in different ways. One, in a retrospective or a monthly chart review of when antibiotics were prescribed or not prescribed based on conditions or appointments where that condition was completed. And also it's been used in more of a note template so that that information is collected in every visit where a patient presents with either tooth pain or swelling or prophylaxis. And then there's pop-ups and recommendations for whether or not antibiotics can be prescribed. So because this area is a place where we're still growing in dentistry, I just wanted to make sure that you had some resources to implement that well, knowing that there's going to be more of a link for this with diagnosis with treatment recommendations and treatment completion.
Thanks, Dr. Kennedy. Next question, when will the next NHSN AU aggregate data be updated? I believe the last data was from 2017.
I can take that. So the baseline, yes, was done in 2017 using 2017 data for both the adult population as well as the pediatric, and then the neonatal population was 2018. And we hope to do a baseline potentially using 2022 data or 2023 data. So hopefully maybe next year I'll have an update for you all.
Thank you. Another question for Dr. Kennedy. Thank you, Dr. Kennedy, for the great talk. What time frame would you consider to determine if patient has immediate access to dental care?
Absolutely. Before I answer, it's 1 to 2 days, but when you pick up the guidelines that I dropped in the chat earlier, below all the recommendation tables, there's the notes. That is where the gold is for the entire clinical practice guideline. Every single one of those comments or distinctions was one, an area of research across multiple different groups to make sure that we were using guidelines and recommendations that were seen elsewhere. And so I highly recommend don't skip over those notes in the table, because that's where all the gold is. And that's where most of the questions that come about how to use these guidelines come from. But what our recommendation was, if you read the guidelines, is immediate dental care is within 1 to 2 days. And so if you think about it in the context of clinical practice, let's say you see a patient on a Thursday, your office isn't open on a Friday, and that patient can't get in till Monday, that's not able to receive immediate dental care. Immediate dental care is either being seen the next day, but if that patient can't be seen the next day, it would be like the next morning. So you see that patient on Wednesday afternoon, you want to send them to an endodontist to receive care. And immediate dental care would be they were either seen Thursday or Friday morning, basically.
Great, thank you. Next question. What are the best resources? I'm sorry, we already did that one. There we go. There does not seem to be standard definition for immunocompetent in healthcare. It varies from facility to facility and provider to provider. What is the definition of the immunocompetent patient in the dentistry world?
That was another discussion. It's also in the notes below the table. That's where all the gold is. But our definition of immunocompetent was defined by the ability for a patient to mount a response, appropriate immune response. And so there's a gray zone here that I think I need to call out, because otherwise it's going to be another question. Does this include patients with uncontrolled diabetes? That is such a spectrum that we did not make a recommendation on that specifically. However, you can see that immuno-incompetent patients include patients that have a condition like HIV or AIDS, an opportunistic illness, cancer, organ transplant, stem cell transplant, and even autoimmune conditions where patients are on immunosuppressive drugs. And so that was how we defined immunocompetent, was by defining immunocompromised. But you are absolutely correct that this definition varies not only across sites, but across different specialties and different groups. And so that is a challenge, but this is the definition that we used when writing the guidelines. And we look to the American Academy of Orthopedic Surgeons because they have some really great resources for providing prophylactic antibiotics in those patients. And they have a tool, if you guys are interested, I can drop it in the chat, but you can basically put in elements of your patient case, and it gives you a clear recommendation in that gray zone of whether or not you should provide prophylactic antibiotics or not. And if that's helpful, I'll drop that in the chat.
Definitely. Our next question, it says ASP Pharm D here. For long-term care, what does IDPH consider appropriate documentation, i.e. antibiotic log, in regards to tracking of infections and courses of antimicrobial usage? What all specific information needs to be included? We see huge variances in reporting standards and practices from our homes, which makes retrospective reviews difficult and time-consuming.
I can start. I did put into the chat the Minnesota Excel file, which I would say is probably a really good template for exactly what you're asking for here. I don't know if anybody else has any other, but that would be the fastest way to get that type of information. What it basically gives you is your standard demographic information. Then it also gives you, whether they meet the criteria for a surveillance definition. In this case, it's the McGear definitions, the revisited McGear definitions, but it also gives diagnosis, symptoms, and then it's start and stop dates, any side effects. It's really well done. And then it automatically calculates days of therapy. I don't know, does anybody else have any other tools that might be helpful? But that would be my suggestion for where to start.
And if you think of any resources that should be added, feel free to just post a comment for others to see in the chat. For our next question, we tend to see repeat testing for ESBLs and urine from PCPs as outpatient for testing for cure. And many of these patients are colonized, and also then the nursing home will send some of these patients to the ED for evaluation with any onset confusion issues and wind up adding carbapenems based solely on history while urine cultures are pending. Is there a reference to help nursing homes understand colonized versus acutely infected? We have shared the symptom-free P flyers, and that confusion is not always a sign of infection.
I can take this since I've been doing all the UTI ones. But so yes, I'm going to put into the chat the guidelines that are updated on asymptomatic bacteriuria, which is what you're referring to, colonization versus acute infection. And it actually goes through how to the definitions. And even if you don't want to go through the whole guidelines, the first page has just a summary of the recommendations, which makes it easy to browse. So I'll plug that into the chat after we've done. The other thing is, it's also important to think about, is a catheter, is there any hardware associated with this infection or not? And how are these samples collected? If it's that 100% of the time, I think there's confusion because the sample wasn't really collected from the place it should have been collected, from a fresh urine specimen. So there is also not just about what's and colonization versus infection, but also about how do you even start with collecting the sample appropriately to make that judgment call. So I'll put that in there. And if you have any other follow-up questions, you can also just put it in the chat. And I just wanted to also mention that Minnesota tool is great, but what another tool a lot of healthcare facilities have used in the past for antimicrobial stewardship is their electronic health records. So if you have certain EHRs can generate reports on antimicrobial stewardship that have a lot of those data elements that the Minnesota tool has. So in case it's more labor intensive to think that you have to manually input something like that, at least it helps you know what are the elements in the report that you need to use to generate from your EMR. And hopefully someone in your EMR can say, yes, you just tell us what you need and we'll be able to pull that out if your EMR can collect that kind of discrete data.
Thank you. The next question is, what about antibiotic orders coming from the hospital with new admissions? That's where most of the new antibiotic orders starts and new infections are coming from, but they get entered under our facility providers' names. They're attending docs while at rehab. The report cards for antibiotic prescribing by our facility docs, antibiotic start data, and infection data doesn't seem meaningful or accurate. Too much of it is lumped together. Any guidance on how to overcome that?
Okay, I'm really interested in what the prescribers have to say about this too, because this is something that we did address, and it took a while to do this. But with whoever our providers were, once they came into they were admitted in, trying to get a hold of whoever ordered that in the first place. And basically what we came down to with our medical director, who we worked with, medical directors who we worked very closely with, were basically, if you had an ID consult with the order, that it put it in a different category, and we generally didn't touch those because you had ID consults on that. However, if it was just something that was thrown on and it didn't seem like it was a good fit, then it was our prescribers that really followed through with those types of orders. I don't know if that's helpful or if anybody has anything else to say. And our prescribers got pretty comfortable with, if it didn't have an ID consult involved with it, or if it wasn't obvious. I mean, you're talking about the infection data doesn't seem meaningful or accurate. Sometimes that it was like other medications. Proton pump inhibitors are another great example of that, where they get overprescribed, and they had our prescribers sort of ended up cleaning up things, which could include antibiotics.
Thanks, Deb. Next question. In my long-term care community, I see more inappropriate prescribing from the ER and local hospitals. Any advice on combating that issue?
And that's the same phenomenon. You get your prescribers, you get your physicians, and your other prescribers attuned to the fact that the residents are going to come back with things that they shouldn't be on. And why are they on it? I'll use proton pump inhibitors again. Overprescribed. We did some data, and we found that over 50% of the proton pump inhibitors that the people were coming in on had no diagnostic indication. Same thing with the antibiotics. You've got it. You work as a team, and long-term care, you guys are great at interdisciplinary teamwork, and that's just part of it. Getting your pharmacy and your physicians, your prescribers together.
And I would just add, it is so important to establish and strengthen those cross-setting partnerships with your local hospitals as well, to ensure that we are improving appropriate prescribing between both settings as well. So the next question we have you seen an increase in the number of patients in the community who are more aware of antibiotic prescribing? If so, what do you contribute to the increase?
I think I can try to take this one. Feel free to. So, what I have noticed as a prescriber is that there's less resistance now to convincing patients that they don't need antibiotics. I think CDC has this great toolkit for people who come in with, it was actually a prescribing pad for those who come in with like a viral cough or what we call a viral URI. And you just, instead of handing them the prescription, you hand them this little thing and they say so how to manage it. And I think that was very helpful for a lot of our providers when we were trying to manage the ambulatory prescriptions, antibiotic prescriptions for viral URIs. So there's less pushback on the behalf on the part of patients now. A few exceptions, but in general, it's easier to convince them that antibiotics are can cause them more harm than good in certain situations.
Yeah, we continue to try to educate in the community setting through like a lot of different opportunities and partnerships. And this is just speculation, but I think we think that some of the COVID, understanding that COVID is a virus and antibiotics do not help improve COVID, but there's other treatment modalities specifically for viruses, potentially has helped educate those in the community.
So we can thank COVID and Melinda for the increase in awareness. So our next question, does the CDC have any recommendations regarding antibiotic surgical site irrigation?
Not that I'm aware of. I think there was a post for some information on that.
Yeah, Mary Alice posted something in the chat that she said may be an option. Let me see if I can find that again. But she did drop something in the chat. Shannon, can you find that to click on that maybe? Or Jamie?
Yes, I'm going to right now. Yes, I do see it. So Mary Alice did post a possible resource for wound irrigation question. There's a link to an article here. Thank you, Mary Alice.
And then I've seen, just real quick, a couple questions that the link that I provided wasn't working. So I went back in, and it is under the implementation guide for long-term care, the antibiotic stewardship in a toolkit. So it's under the tracking section of that. And it's from Brown University, I believe, but it's a tool that's listed under the CDC resources. So I put that link for CDC in there. Thank you.
The next question from Jamie Borkowski. I recall a discussion about creation of regional antibiograms in the past. Any headway on creating something like this for Illinois? I can take a stab at this. So there are two stakeholders that are currently working on this. So we have a long-term care pharmacy, Green Tree Pharmacy, that may have already reached out to leadership at your hospital to try and pull your antibiogram data to create regional antibiograms that are specific to the Idph regional map that we have, as well as Dr. Vidya Sundareshan at SIU is also working in that region as well to create a regional antibiogram. So more to come on that. Hopefully in the coming years, we'll definitely have something more concrete in this area. It looks like a number of the comments in the chat are more resources. So I would definitely encourage you, if you asked a question, to review the rest of the chat to make sure that you are aware of the links that have been provided, maybe copy them over, make some bookmarks for antimicrobial stewardship. I'm just going to keep scrolling for some more questions. Dr. Barnes, perhaps you can take this question as well from Annette Pilar. Can you discuss the difference of UTI versus bacteriuria? If a patient is not meeting the criteria, the McGear's criteria, prescribers will give the diagnosis of bacteriuria when prescribing antibiotics.
Yeah, and so no bacteriuria. So if it's bacteriuria, it just means that there are bacteria in the urine that are present and are not really causing infection. So sometimes the presence of pus cells in the urine or white cells are not necessarily very indicative that this is a real infection, but you can also look at when the bacteria grow, the colony, like how fast these bacteria grow, how many colonies of these bacteria grow. So I put into said the chat the guidelines for asymptomatic bacteriuria management. But the key thing is really, is this person symptomatic? Because just a UA may not really indicate that. Just a urine test can look like it's you see pus cells in there, you might see bacteria growing in there, but truly, is this person symptomatic? Are they having symptoms? And that is sometimes the key definition. Now, for those who are not able to demonstrate symptoms, the symptoms may not always be verbal. They may have pain when you're pressing on their suprapubic region, or discomfort, or have different kinds of manifestations of pain, even those who are nonverbal. So symptomatology is key between defining whether it's asymptomatic bacteriuria versus a UTI. And it's helpful to look at the urine, but it's not 100% what we call 100% slam dunk if you see white cells or pus cells in the urine that this is a UTI.
Thanks. Lots of UTI questions. I hope we all become experts in UTI management after this session. Next question we have from Sarah Franks. Are there any specific toolkits for local health departments to use for promoting antimicrobial stewardship and/or MDRO response and investigation in long-term care facilities?
I am not aware of any. Deb, have you?
No, I try to like to stay on the same page. So, using those CDC tools probably would be the same. Does anybody else?
I mean, if it's in a local health department, I think it would be a lot of the educational materials that would need to just be shared by local health departments with public service announcements, et cetera, to the prescribers within their own communities, things along those lines. But I do not know, again, like Deb said, any specific toolkits that were bundled together to create a actual local health department kit.
And CMS or CDC and CMS, but mostly CDC with Project First Line, you've got so many cool little tools out there that CDC has just there's just some really neat stuff coming along. I mean, it's a good time to be around because you don't have to reinvent the wheel. I'm not big on reinventing
Videos,
the wheel.
flyers, all kinds of, like I said, public service announcements that can just be maybe aired or put on TV, whatever the case might be, to providers and the community itself, as far as not having that mother that Deb mentioned earlier going and begging for an antibiotic for mom, those types of things.
Yeah. And as long as we're doing this, because there is a sort of a corollary chat, and it goes back to what Dr. Barnes was just talking about. It goes back to this. Using the proper definitions when it comes to defining what is an surveillance definition versus what is Leanne Walls put it in there, and she did it very well. The difference between a surveillance definition, where you're looking at populations and things like the lobe criteria, the minimum criteria for starting an antibiotic, which is a person-centered tool, those things are really important to understand, to tease out. Don't try to do this on your own. There's lots of stuff out there that can really help you develop your surveillance and your understanding of back to what's happening in your facility and what, what's appropriate and what's not. And I may be frozen again.
No.
You're
Okay.
good, Deb.
Okay.
You're good.
Okay.
So the next question from Amy Hansen. Deb or Karen, would it be helpful to clarify in long-term care the difference between McGear's and the Loeb criteria?
Yes, and that's Amy. That's exactly between Amy and Leanne. That's exactly what I was sort of going for.
Yeah.
Loeb criteria for our person-centered, minimum criteria for when should you consider starting an antimicrobial agent. McGear, the revised McGear definitions, which Dr. Stone and Stone et al. Redid from Dr. Allison McGear's long-term care infection surveillance definitions, which were started in 1991. So they've been around for a while, and they've been revised twice or three times. Those are surveillance definitions. So, and I'll just clarify this since Amy asked. Just because somebody shows up as meeting the surveillance criteria for an infection does not necessarily mean that they need to be treated, because you're talking about populations versus people. And so that is something, it's one of the finer points that an infection preventionist needs to know, because I have had situations where I have been told when teaching classes, not necessarily in Illinois, where you would have an infection preventionist come and tell a prescriber that they had to stop a particular antibiotic because the person didn't meet the McGear definition, or vice versa. And that is not the intent of a surveillance definition. So the Loeb minimum criteria are very important.
So next question, what is the impact of monotherapy versus multiple or combination antibiotic therapy on antibiotic resistance?
This is Aarti here. I can try to take this one. So in general, I think this question came up before about narrow spectrum, the spectra of therapy. So the fewer antibiotics you use, more likely you're going to get a pretty narrow spectrum. So some pathogens truly do require multiple combination therapies, but those are rare and few. Those are, I would say, high level complicated infections. Most of the time, it's not just monotherapy, it's the type of monotherapy that will impact antimicrobial resistance, because some monotherapies are very broad spectrum, like azithromycin. Some monotherapies are narrow spectrum, like penicillin. So it's which monotherapy you're using that will really define the impact on antimicrobial resistance. Even so, Bactrim is also fairly broad spectrum for the most part, and has been over time associated with antibiotic resistance. So more antibiotics worse than fewer antibiotics, but even fewer antibiotics or even one antibiotic can be just as bad if their spectrum is very broad.
Thank you. I believe we have answered all of the questions. I'm just skimming through just one last time. Oh, it looks like we do have a question. Dr. Kennedy, what are your views on use of amoxicillin or clindamycin for prophylaxis for a patient with history of aortic valve or mitral valve replacement for annual teeth cleaning?
I dropped a recommendation in the chat so that you can look at the context of the full patient case, their medical history, and there's really clear recommendations. What I will say is that over the last few years, every time the American Heart Association and the American Dental Association get together and talk about prophylactic guidelines, they are less and less. And our goal really is to also stay away from the use of clindamycin, even if it's one time. There was another question about oral surgeons that you give clindamycin one time pre-op before tooth extractions, like third molar extractions. And that is one of the mindset shifts that was incredibly clear in the guidelines for treating tooth pain and swelling that applies to both prophylaxis and treatment, is that clindamycin has a black box warning. One dose of that puts you at a very high risk for opportunistic infections like Clostridius difficile. And we are trying to shift the entire oral health team away from using that one time, unless it's absolutely necessary, and that is the only antibiotic that that patient can take. So when I say that, and I read that question, amoxicillin or clindamycin, we're really shifting away from that either or. If you look at the treatment guidelines, it goes amoxicillin, and then if the patient has anaphylactic response to penicillin, then it would be use of like azithromycin. But if the patient has like a really mild response due to that crossover, something like cephalexin can be used. And all of those treatment making decisions are included in those guidelines, and they're applying to the prophylaxis guidelines as well. And you can see that in the updated infective endocarditis guidelines that were released in March 2021. There's similar language there, shifting clinicians away from prescribing even a single dose of clindamycin if there were other antibiotics that could help provide the prophylactic protection. So I answered those both in the same, because that's especially the third molar extraction. That's one of the gaps. And actually, I think it was Amy who answered that question. We've gone back and forth about resources many, many times, but I think it's time for me to reach out to my team and say, hey, what's the updated timeline now that we're a few years outside of the start of COVID-19, and what's it going to look like for some of these other treatment guidelines to be released? Because especially for third molar extractions, it's such a contributor to even single dose antibiotics or prophylactic antibiotics in often a very healthy population, a young population. And so that's an area that we could continue to practice even safer practices with antibiotic use.
Thank you for answering both of those questions. Another question that we received: many long-term cares have vent units with very high use of antibiotics. Any thoughts on improving trends there?
Deb, do you have a comment on that? I was going to say it would depend on if they're appropriate or not. That would be my, are they using standing order guidelines to order appropriate antibiotics for whatever bacteria might be showing up? Deb, do you have any comment on that?
No, I would say that those and we've all had this experience going in to care communities that have residents and in these units. They have some really complex needs, and a lot of times those antimicrobials are appropriate for any antibiotic. It does come with the risk, use comes with the risk of resistance, but also too, some of the vent units have had very active partnerships with infectious disease physicians. That probably would be the best thing. So you have somebody who has good knowledge of how to use antibiotics in these very frail individuals.
Yeah, this is Aarti here. So the sad thing is that during COVID, we noticed a complete jump in ventilator-associated pneumonia. Well, we're not sure if they were truly pneumonias or they just high antibiotic use on vents. So that jumped up much higher during the COVID era. So if you're seeing that now, that might be a sequelae of that. They're not sure why that happened. Partly, if you're talking about improving practices, it's because staff are now handling processes and vents and things that they didn't before. So there's less familiarity with how to understand if this is truly something called a VAP, a ventilator-associated pneumonia, or a healthcare-associated pneumonia. What is the definition of that? How much, you gotta make sure you're getting that sample. It's a deep bronchial sample that's enough, what they call CFUs, enough growth in there to really define this as a ventilator-associated pneumonia. So there are, I think, just having your providers get refreshed in what the updated guidelines are for ventilator use, ventilator-associated pneumonias specifically, would help. And having staff that are very dedicated to vent use, that helps decrease it, because we noticed that, again, it was nothing about as much about COVID. Of course, people are needing more vents as a result of COVID, but it's also our restructuring of how healthcare personnel are staffing these units that resulted in a lot of excess antibiotic use too.
So we have about 8 minutes left. There were a few questions in the chat about whether or not the links in the chat will be available after the presentation. So we did confirm that you will still have access to the chat. But I did just want to take, since we have a few more minutes, I think it would be helpful if I just review some of the references that were put in to the chat. And panelists, if you have any other comments to add as I post the links, we can do that as well. So it looks like the first one that came in was from Dr. Kennedy. She posted a link to the non-surgical treatment of periodontist guidelines. So that's there for your reference. Dr. Newhouser then posted a CDC link to the AUR report that someone had requested. It's the NHSN AUR website. Dr. Kennedy also posted the link to the Stewardship Toolkit for Dentists that we discussed that was created by Idph. Another resource that I put in the chat is the general antimicrobial stewardship webpage from Idph as well. Dr. Barnes also posted the IDSA practice guidelines. This looks like an overall link to all of the guidelines that are available, but definitely check out the UTI one since there were a number of questions. We also had a link to the dental toolkit from the CDPH website. Shout out, looks like, to Dr. Kennedy, Dr. Rowan at UIC, and the CDPH HAI-AR unit for your help with these materials. So definitely check out this link. It looks like from many of the comments that this was a really great resource for many of our dental providers. Next, we have a possible resource for wound irrigation that someone had asked for. And we also have, Deb has posted the CMS QAPI toolkit as well. Someone had requested that. Dr. Kennedy had then posted a link with a download to the dental fact sheet, which someone had requested. And Deb also posted a link to the CDC long-term care toolkit with access to the core elements for nursing homes. Amy Hansen posted a number of links in here, so thank you, Amy. She posted the AHR has some great ASP resources for long-term care facilities as well. This is such a great website. Definitely check this out for some more of those toolkits. She also posted a link to the CDC core elements for nursing homes again. Melinda then posted a link for hospital implementation resources for antimicrobial stewardship. We also had reference to guidelines for surgical prophylaxis, I believe, for patients with orthopedic implants and patients undergoing dental procedures. Amy Hansen posted a link to the definition for dental GL, the definition of immunocompromised patients, reference page 33 for that specific definition. What else? There's also a link to the CDC webpage for core elements of nursing homes. Under tracking and reporting section, there's an Excel tracking tool. Someone was asking for that as well. Dr. Barnes posted a recent article on the harms of long-term antibiotics for UTI, outweighing benefits. Another UTI article, as well as the UTI asymptomatic bacteriuria guidelines from the IDSA. And that is everything. Oh, we also have some vent pneumonia guidelines from the IDSA as well for the question regarding how to tackle stewardship in vent units in long-term care settings. And let me see if we have any new questions. So there was a question, will the links be sent to us via email? They will not be sent via email. but the chat will be available for viewing after the presentations. So definitely feel free to save this link. As you view the recording for the presentation, I've posted all these links underneath the panelists, so you'll also be able to see it there as well in conjunction with our conversation. But it looks like that is all the questions. If there are any last few questions, we have about 3 minutes left. Feel free to just pop in and ask any of those questions. Panelists, do you have any final thoughts or closing comments? Thank you so much for being here. You guys have been incredible. Have answered such difficult questions. Thank you to all of our audience members who asked such thoughtful questions and comments. We really appreciate this great discussion we've had this morning.
Thank you, everyone. Pleasure being here.
Hang in there. You're doing good work.
And thank you, everyone. If there are no parting thoughts, we are about to take a quick 15-minute break before we go to the next session. So please go ahead, get a drink, do whatever you need to do for 15 minutes, and then go to stages, and it'll be the 11:15 to 11:45 stage, and we'll see you there.
And Alexis did just ask, how will we be able to view all of this later? On the left-hand side of your screen, at the very bottom, you'll see a replay button. Later during the day, I think about an hour or 2 hours after each presentation, you'll be able to hit that replay button, and you'll be able to see the presentations that we've had earlier today. So we're just at the top of the hour, so I am going to close out of this session. Thank you again to everyone who was able to join and for our incredible panelists. We will definitely see you in the next session. Thank you.